Our patient has a clinical condition, smile line, and periodontal condition, which is healthy and within normal range. The radiographic diagnostics are all within normal range, except that there is a narrow amount of bone in the apical part of the implant site. We start off with local infiltration anesthesia in the buccal vestibulum, in the palatal vestibulum, and in the marginal gingivas, including the papillas. Periodontal probes are being used to sound to the bone. The surgical guide stent is applied and evaluated with the surrounding soft tissues just prior to starting the procedure. A microblade is being used to make a crestal and marginal incision around the adjacent teeth. A periosteal elevator, Joe 1, is applied full thickness to the soft tissues, elevating the palatal and buccal flap and demonstrating the palatal and buccal and crestal bone. The surgical guide stent is stable and applied on the posterior teeth and ready to be used in conjunction with a precision drill at 2000 RPM. Precision drill is applied exactly into the area of the surgical guide stent for the appropriate aesthetic crown fabrication later. An evaluation is done with the surrounding teeth and the bone. The next drill is the 2 mm twist drill with external irrigation, still using the surgical guide stent for its optimal position. Then the surgical guide is removed and good access is allowed to continue with the osteotomy. An implant probe is being used to detect any perforations, and indeed in the buccal apical area, in the narrow part of the bone, a small perforation is noted. The next drill is the 13 mm taper drill, which is applied to the handpiece with an extension, and the drill speed is reduced from 2000 to 800 RPM. This extension and drill allows access next to the teeth, as well as good control of the position and direction of the drill. Full length is being achieved, and at this moment the implant probe is again inserted into the osteotomy to evaluate for any kind of perforation which was noted in the apical area. To access the buccal perforation, a vertical incision is applied using the microblade on the distal buccal line angle of the first premolar. Full thickness flap elevation showcases the buccal bone, and using an implant probe, the perforation can be directly accessed and evaluated for size and complexity. In this implant site, the perforation is moderate and at the apex of the implant osteotomy. The final drill is the regular platform 13 mm taper drill, again used with an extension. The osteotomy is now finalized with this drill to full length, and again taking note of the apical narrowness of bone and the perforation. Here, the check of the position with the surgical guide confirms the optimal mesiodistal buccolingual position, but as well the minor perforation at the apex, which is showcased in this view. The surgical flap is evaluated for tension-free closure, and then final check of the position using a direction indicator and the surgical guide shows the optimal position of the implant in relationship to the crown. Good bone surrounding the implant at the crestal area, and now we're ready for the implant. We're using the 13 mm conical connection, tapered implant, a regular platform, long shaft driver is being used, again to gain good access in between the adjacent teeth. The driver is picking up the conical connection implant from the titanium sleeve, and the osteotomy is being irrigated for the last time to remove any kind of final soft tissue, and implant ready to be inserted. At this moment, we're starting with a 20 Newton and allow the blood clot to have direct contact to the tyenite surface, which is shown here in this view. Further insertion is continued. Then a slow reversal, and a second insertion torque of 30 Newton is being applied. Now we're at 30 Newton. Almost at final position. Again, there's a reversal, so we're picking up more stability. And now we're inserting the implant at 40 Newton per centimeter. Now we're ready to place the implant in the final position and leave it at bone level. Here's the final position, right at the buccal bone level, and showing a good thickness of buccal bone, and then elevating a full thickness flap to allow sufficient space for the bone graft to be placed around the apex of this implant. The bone graft of choice here is a mineralized, particulated cancellous xenograft, which is being inserted into this bony deficiency and on the exposed apex of the implant. Approximately 2 millimeters of buccal bone will be applied on top of the titanium, and also allowing a good convexity in this area to counter the bone deficiency in this site. As it was a very moderate defect with only an apical extension, and only bone substitute was used in this site. A GBR resorbable natural cross-linked collagen membrane was used in the size of 13 by 25 millimeters, and the corners were rounded and trimmed to be able to fit nicely over the bone defect and over the previously applied bone graft material. This naturally cross-linked collagen membrane allows good stabilization in a moderate defect like this, just with hydration of sterile water. And here, a gentle pressure is being applied to place it under the flaps of this site. Due to the high initial stability of the implant, an immediate temporization concept will be utilized, and you can see here the selection of an open tray impression coping. The coping will be attached securely to the implant. The flap will be sutured temporarily around the coping so that the impression will have an estimate of the eventual soft tissue margin. The suture material utilized here is an expanded PTFE, and as you can see, the placement of these sutures, placing the flap very close in approximation of the impression coping. Also, the vertical incisions are being closed, and some of these sutures will stay as the final sutures, and some of these sutures will be removed and then replaced after the impression coping has been removed. The final sutures in the papilla area are 6-0 nylon sutures. A custom tray is being used to take the impression of the implant with the open tray coping. Impression material of choice is being used in the implant site as well as in the tray. Careful attention is being applied that the coping is accessible for the screwdriver and an accurate impression can be taken. A healing abutment of appropriate height is chosen, here 5 millimeters, and will be secured into the implant site for the period of the fabrication and modification of the abutment as well as the temporary acrylic crown. And stabilization of the healing abutment will be maximized at 20 Newton per centimeter. Based on the gingival thickness and the measurements taken around the implant, a zirconia stock abutment is chosen with the appropriate height and dimension. In this case, the number 12 regular platform zirconia abutment. This stock abutment will be used in the laboratory phase to fabricate the temporary acrylic crown. It can either be done in office or out of office in a professional laboratory. Here you can see the steps which were followed to modify the zirconia abutment and to fabricate the temporary crown in a professional laboratory in a few hours after the implant was placed. From there, the abutment and temporary crown come back to the office and the healing abutment can be removed and abutment inserted. The abutment is carefully inserted not to traumatize the tissues and to be very precise in its location. Here you can see the application of a jig to ensure the proper angulation of the abutment. A prosthetic torque wrench is used to secure and stabilize the stock abutment with 15 Newton per centimeter. This is a reduced torque due to the immediate function concept used in this patient. Once the implant is integrated, the final torque will be placed at 35 Newton per centimeter for this zirconia abutment. Now the temporary crown can be inserted on the abutment and evaluated for marginal fit and for occlusion and lateral forces so that there's no contact in this immediate temporization concept. Any premature contact is carefully being removed prior to insertion of the temporary crown. The access hole of the abutment is occupied with a filler like a cotton pellet or impression material. Then we're ready to insert the temporary crown with cement onto the abutment. For the purpose of the immediate temporization, we'll use a cement which is of temporary duration so that the crown can be removed when needed. As a final step in today's procedure, a probe or explorer is used to remove any excess cement from the subgingival space. Here are the final photos of the temporary crown in position in relationship to the gingival tissues, in relationship to the smile line of the patient and the lip line. A periapical X-ray was taken and confirmed the optimal position of the implant, respecting all important structures and confirming the seating of the zirconia abutment into the implant. So Fielden, we're done. You've seen we've worked hard to do the implant procedure, place the implant and a little bit of the bone graft. From your perspective, was this What you expected? Was it worse?
It was not worse at all. It actually turned out really great. I'm very happy with that.
You can look at it and tell us what you think. So I have a nice mirror for you. You can smile.
Yeah.
But you can see the shape and the form.
Looks good. Very
You happy?
nice. Very nice. Yes, I am. Thank you.
For more education programs, visit the Guide Institute at www.guidedental.com.